Somos a Unifesp, Universidade Federal de São Paulo, e temos a missão de defender e expandir a educação pública, gratuita e de qualidade no Brasil. Atualmente, a Unifesp possui 7 campi. No campus São Paulo, ficam a Escola Paulista de Medicina e a Escola Paulista de Enfermagem. Na Baixada Santista estão o Instituto de Saúde e Sociedade e o Instituto do Mar. O Instituto de Ciências Ambientais, Químicas e Farmacêuticas está localizado em Diadema. No campus Guarulhos, localiza-se a Escola de Filosofia, Letras e Ciências Humanas. Em São José dos Campos está o Instituto de Ciência e Tecnologia. No campus Osasco, localiza-se a Escola Paulista de Política, Economia e Negócios. O Instituto das Cidades é o mais novo da Unifesp e está localizado no campus Zona Leste. A Unifesp é para todos. Universidade pública, gratuita e de qualidade.
Para você tirar medida, né?
Estamos no ar.
Boa tarde a todos e todas. Eu sou a professora Solange Ghisilini, sou professora associada da graduação e do programa de pós-graduação estrito sensu da Universidade Federal de São Paulo. Sejam todos bem-vindos mais uma vez. Vamos dar continuidade ao curso de atualização em cirurgia cardiovascular, um curso de transplante cardíaco em associação com o Instituto de Transplante de Miami, da Universidade de Miami. Hoje nós teremos o nosso segundo encontro. Algumas informações importantes em relação ao nosso encontro. Receberá certificado do curso o participante que frequentar, ou seja, tiver uma frequência maior ou igual a 80% dos nossos 12 encontros síncronos, levando em consideração que na semana passada nós iniciamos, então nós vamos começar a contar a presença a partir de hoje. A lista de frequência será disponibilizada no chat do YouTube durante todo o momento. Então, durante todo o momento da nossa aula, os senhores poderão acessar o link e registrar a sua frequência. Como será a nossa dinâmica de hoje, do nosso encontro? Bom, é com grande prazer que nós recebemos aqui a professora Hoda Butrous, da Universidade de Miami, do Instituto de Transplante de Miami. Após a sua palestra, o professor Dr. João Breda, também professor da Universidade de Miami, do Instituto de Transplante, seguirá colocando um highlight sobre a aula da professora em português. E a seguir, o professor Dr. Walter José Gomes, que é professor titular da disciplina de Cirurgia Cardiovascular da Universidade Federal de São Paulo, irá, então, dar início à discussão em relação ao tema. Importante colocar que qualquer pergunta que vocês tiverem, pode colocar no chat, inclusive perguntas em português que nós repassaremos, então, para a nossa convidada. Agora, então, eu convido o professor Dr. Walter José Gomes para presidir essa nossa palestra. Por favor, professor, é um grande prazer recebê-lo aqui também. Por favor, professor, ative o seu microfone.
Prazer é todo nosso. Hoje, então, nós temos a segunda aula, que vai ser ministrada pela doutora Hoda Butrous, que é MD, PhD, e é Heart Failure Specialist, e specialized in heart transplant e mechanical support do Miami Transplant Institute. Hello. Speaking again. Today we have for the second class Dr. Hoda Butrous. She's a heart failure specialist, specialized in heart transplant and mechanical support. the Miami Transplant Institute, and she's going to speak about the advanced heart failure therapy, the Miami perspective. Dr. Hoda, thank you for accepting our invitation to take part in our course. It's a pleasure to have you here, and just the screen is yours. Please proceed with your talk. Thank you very much to be here.
Thank you so much for the invitation. I hope this is useful for everybody, and I'm glad I was part of this collaboration, and I would be happy to answer any question at the end of the talk. We can start the presentation. Is it uploaded or? So today I'm going to talk about advanced heart failure. Before talking into discussing advanced heart failure, I think it's important to learn all about heart failure. Heart failure is a very common disease. It is a chronic progressive clinical syndrome due to structural and functional abnormality of the heart that affect filling or ejection of blood. It is associated with significant mortality and morbidity, and also extensive expenditure, which is a very costly disease on the healthcare everywhere in the world, especially among elderly patients. In the United States, we have more than 6 million Americans who live with heart failure, and we expect this number to increase to 8 million by 2030. Out of the 6 million that we have now, we have 200,000 patients with stage D heart failure, or what we call advanced heart failure. As I said, it's a very costly disease. We have an annual cost of $30.7 billion in managing heart failure currently, and we expect this number to reach to $70 billion by 2030. So as you find out, since it's a very common disease, it's important to learn about it. And we have a new classification for heart failure by ACC/AHA, and it's been there for a while, but it's meant to help us recognize heart failure early. Also, we have 4 stages of heart failure. Stage A, which is at risk, or people at risk for heart failure, which basically will be every one of us. So patients, people who have risk factors to develop heart failure could be patients who have diabetes, patients who have obesity, have been exposed to cardiotoxicity, people with genetic variants for cardiomyopathy, family history for cardiomyopathy, people who are inactive, obese, at high risk for heart failure. So we call them at risk for heart failure stage A. So by definition, they don't have any current or previous symptoms or signs of heart failure. They don't have any structural abnormality in their heart. They don't have any abnormal biomarkers, but at risk for developing heart failure in future. Stage B, or pre-heart failure, define patients with current or previous symptoms or signs of heart failure. Sorry, I thought you will be advancing. Okay, sorry. Okay. I thought you would be advancing the slides. So stage B heart failure. On stage B heart failure, it's pre-heart failure. We call them patient without current or previous symptoms of or signs of heart failure, but they have a structural abnormality in their heart. They have evidence of increased filling pressure. They could have a low EF or have LVH by echocardiogram, but they never ever been admitted for heart failure, never ever had any congestive heart failure symptoms. And we call these pre-heart failure. stage B, and ACC/HA classified them as a stage B because we can treat them with beta blocker, ACE inhibitor, ARB to decrease the progression of the disease to stage C. Stage C on symptomatic heart failure, any patients who had either previous or current symptoms of heart failure, congestive heart failure symptoms, they will classify as stage C. Then we come into stage D on heart failure, which is marked heart failure symptoms that interfere with daily living, recurrent hospitalizations despite being on any attempts to uptitrate GGMT. For me, I specialized in treating patients with stage D heart failure. I still see patients with stage C, but my big part of my daily work is to identify patients with stage D heart failure. This is on the diagnostic algorithm for patients with suspected heart failure. Once we suspect heart failure, diagnosis based on clinical history, based on physical exam, we get EKG labs including pro-BNP. I advanced the slides. Are you at the diagnostic algorithm for patients with suspected heart failure? Hello?
Oh, we are here. You can go forward, please.
Yeah. Okay. So once we suspect diagnosis of heart failure based on clinical history, physical exam, EKG labs, which mean high pro-BNP, we do transthoracic echo to confirm the diagnosis of heart failure, and we do additional testing if necessary. We'll talk about it later. Once all heart failure diagnosis is confirmed, we can classify heart failure based on EF into 3 types of heart failure. Heart failure with reduced ejection fraction if LVEF is less than 40%. Heart failure mildly reduced ejection fraction if LVEF is 41 to 49%, or heart failure with preserved ejection fraction if the EF is more than 50%. And then we should be evaluate for any precipitating factors and then initiate treatment. One of the important steps in after diagnosis of heart failure is to try to identify the cause for heart failure, because identifying the cause for heart failure can help us define the treatment. So, for example, if we have ischemic cardiomyopathy, the treatment will be part of the treatment will be revascularization. Dilated cardiomyopathy, we have all different forms of dilated cardiomyopathy, anywhere between inflammatory, familial, environmental, and if we cannot identify the cause, idiopathic cardiomyopathy represent 20 to 30% of the cases. As I said, identifying the cause will help if we have a specific diagnosis like ischemic cardiomyopathy. Revascularization is the treatment of choice. If we have patients with amyloidosis, it has a specific treatment. If we have a patient with sarcoidosis, it has a specific treatment. So we will try to identify if there is a specific diagnosis that will be treated differently. Other than these cases, everyone will be treated with guideline-directed medical therapy. We don't do cardiac MRI for everyone, but right now, if we have a patient with non-ischemic cardiomyopathy that we are trying to identify the etiology, cardiac MRI and genetic testing has been very prevalent. We try to identify these patients early on. So cardiac MRI will help to confirm the diagnosis of cardiomyopathy. can help us identify infiltrative diseases like all amyloidosis, can help us identify specific all patterns like sarcoidosis, which will be treated differently than just all guideline-directed medical therapy. This is all initial classification of heart failure based on ejection fraction. We do initial classification, then we reclassify patients by serial echocardiograms. As I mentioned, reduced ejection fraction 40% or less, mildly reduced ejection fraction 41 to 49%, and will preserve the ejection fraction more than 50%. After we put the patients on guideline-directed medical therapy, especially for patients with heart failure reduced ejection fraction, on guideline-directed medical therapy, which is like beta blocker, ACE inhibitor, ARB or ARNI, ARA, aldosterone receptor antagonist, and SGLT2 inhibitors. Once we have the medications on board for 90 days, after 90 days, we repeat the echocardiogram. And at this stage, we can reclassify patients on either they continue to have low EF, so we call them heart failure with reduced ejection fraction, or if the EF improve, we now have LVEF more than 40%, we call them heart failure with improved ejection fraction. The ACC/AHA guidelines, new guidelines, changed. Previously, they used to be called recovered EF. And this term has been changed to improved EF because there is a concern that even if the EF improved, this heart is not normal, and they need to continue to be on the guideline-directed medical therapy. And it's also EF is the change is not unidirectional. I have a lot of patients who have improved EF, and after a few years, the EF start dropping again. So we cannot call it recovered EF. I think improved EF is a better term. NYHA classification is we use it day and night in identifying the severity of our patients. It is very simple, but very limited at the same time. If we go from NYHA classification where the patient has no limitation to physical activity at all, to NYHA classification 4 where the patient is unable to do any activity due to exertional dyspnea or fatigue, or patient has dyspnea at rest. We were relying on NYHA classification, but we find that it is deficient and very limited in identifying the severity of advanced stage heart failure patients. It is very limited in identifying who is at high risk for morbidity and mortality. And because of this, we came into a different classification, which is called Intermax clinical profile. Unlike all the ACC/AHA, where we have stage D is the worst, and we NYHA classification where we have class 4 is the worst, Intermax profile has Intermax profile 1 is the worst patients. We have Intermax profile 1 is the clinical cardiogenic shock patients, where we call them crashing and burning. The patient is on multiple pressors in cardiogenic shock, multi-organ failure, and these are all Intermax 1. And these are the patients that at high risk for mortality. And based on our new allocation systems, they get priority for transplant. Going to a higher Intermax, so we get less sick patients. Also, Intermax 1, 2, and 3 are the patients who are on inotrope with different severity. Then Intermax 7 are the patients with NYHA class 3 symptoms. So it's a better way to identify the severity of heart failure patients and the severity of their symptoms compared to NYHA classification. So if I write in my note NYHA classification stage 3 or 4, it could be Intermax 3, it could be Intermax 2. it could be Intermax 4. So it's a better way of identifying the severity of our patients. This slide is all combining the AHA ACC stages with NYHA classifications and Intermax profiles. As you see, the Intermax profiles start correlating much better with NYHA, with the severity of the illness. NYHA 4 and 3 could be from Intermax 1 through 5. The objective of when I talk with patient, with cardiologist, or I try to teach anyone about advanced heart failure, I want to achieve 3 objectives. I want everyone to be able to recognize advanced heart failure phenotype. I want residents, internists, and cardiologists to be able to refer all possible candidates for advanced heart failure as soon as possible, early referral, and know all basic of contraindications of advanced heart failure and the role of palliative care as an alternative. So what is advanced heart failure phenotype? It is actually not a single condition. It's not that can define advanced heart failure. It is a pattern of clinical characteristics that may suggest that the patient is suffering from advanced heart failure. And we have multiple classification, we have here, as I said, it's a group of things, like dyspnea and fatigue with exercise intolerance despite optimal medical therapy, cardiac cachexia, unintentional weight loss despite being on adequate calorie intake, refractory volume overload and edema despite escalating diuretics, progressive worsening of renal function, which is unexplained, hypotension with blood pressure mostly less than 90 systolic, if the patient has refractory arrhythmia with or without ICD shocks, or patient with congestive hepatopathy. So it is a pattern that we have to be trained to identify in order to send the patient early or initiate the evaluation for advanced therapies early. So again, it's progressive and or persistent severe symptoms and signs of heart failure despite optimum medical therapy and device therapy. European Society is calling it advanced heart failure, is calling it advanced heart failure, but AHA is calling it refractory or stage D heart failure. Regardless of the name, it is evolution or progression of heart failure, and it can happen as evolution progression of chronic heart failure, or it can happen as acute heart failure after acute myocarditis. So I've seen patients with acute myocarditis that end up in cardiogenic shock requiring advanced heart failure therapies, either LVAD or transplant, and I've seen patients who have heart failure for many, many years coming with acute decompensation, cardiogenic shock needing advanced therapies. So the diagnostic criteria by European Society based on NYHA classification is 3 or 4: severe cardiac dysfunction, episodes of pulmonary or systemic vascular congestion despite escalation of diuretics, more than 1 hospitalization for heart failure in 6 months, and severe impairment of exercise intolerance, which is described either on max VO2 12 to 14 ml per kg per minute, or we have a 6-minute walk test less than 300 meter. If you look at number 1 and number 4, the severe persistent symptoms and the severe impairment in exercise capacity, both of these can be non-specific. They can be present in someone who has pulmonary disease. It can be present in someone who have advanced stage liver failure or renal failure. They can have the same symptoms, but what is important to add is the severe cardiac dysfunction. either on systolic or diastolic dysfunction that will result in, so these symptoms has to be related to cardiac impairment. Again, on a background of guideline-directed therapy, severe symptoms, evidence of severe congestion despite being on high-dose diuretic, more than 160 milligram of Lasix or equivalent dose of other diuretics, evidence of decreased cardiac output, including organ dysfunction or hyponatremia and cachexia, RV failure, pulmonary hypertension, arrhythmia, ICD shocks, hypotension, recurrent hospitalizations, intolerance to guideline-directed therapies. I've seen this a lot, where we have patients diagnosed for heart failure, and we start them on guideline-directed therapies. Many years later, patient was start coming with dizziness, lightheadedness, hypotension, and we start subtracting their ACE inhibitor, ARB or ARNI, or decreasing the doses of beta blockers. And this could be alarm, red flags that this patient is progressing from class C to class D heart failure. So the AHA diagnostic criteria for advanced heart failure not very much different from the European Society. So again, repeated hospitalizations, more than 2 hospitalizations in 1 year, progressive deterioration of renal function, weight loss, intolerance to guideline-directed therapy, escalation of diuresis, inability to walk 1 block on level ground due to dyspnea or fatigue, persistent dyspnea or hypotension is very much on the same. When to refer patients to advanced heart failure specialists. So the prognostication of heart failure is very complex. And with this pattern, I repeated like 3 or 4 slides, repeating the same thing about features of advanced heart failure, the phenotype of advanced heart failure patient, because it's important for me to have everyone on the chat understand how to identify these patients early, because it is important to identify early, and it's not easy. Even among cardiologists, it's not easy. It's to identify these patients. And sometimes, most of the times, actually, we see the patients referred to us at late stages where advanced therapies are not option anymore. So it's important to refer these patients to us early, or to advanced heart failure specialist early, whenever you suspect advanced heart failure. Any suspicion, it is never too early to refer a patient to advanced heart failure specialist. If you have any suspicion that your patient have advanced heart failure, it's better to have a heart failure specialist look at the patient and evaluate them early, rather than lose the opportunity to be evaluated for these therapies. So we want to see them before irreversible non-cardiac dysfunction, meaning liver dysfunction, kidney dysfunction, before they develop irreversible pulmonary hypertension, and before they develop irreversible frailty, because all of these can make them not a candidate for advanced heart failure therapies. The mortality of advanced heart failure is very, very high. So patients who suffer from heart failure, either preserved or reduced EF, have very high mortality, especially patients with EF less than 25 to 30%, they will have worse prognosis. If you have RV dysfunction, it is associated with adverse prognosis, regardless of the ejection fraction. Patient with advanced heart failure is associated not just with increased mortality, but also poor quality of life. So this is a survival after diagnosis of advanced heart failure. There are many studies I included this one which is showing that at 1 year, 50% of the patients with advanced heart failure would die within 1 year, and 20% survival 5 years. And this is actually one of the better numbers, because I have other studies that showed that if you have the patient on inotrope, it means that they have less than 10% survival rate. Another study, which is a rematch trial actually compared patients who were not candidate for transplant to go into a DT LVAD HeartMate XVE compared to other control group who only received the medical therapy. And the results from this rematch trial, that the patients who have stage D heart failure who were treated medically, 75% died at 1 year, and none of them were alive at 2 years. Compared to patients who had the LVAD, the survival was in the LVAD group 52%, and this was like years ago, even with early technology of the LVAD. This is the typical course of heart failure: is remissions, exacerbations. This is one, when we diagnose heart failure, when patient gets admitted for the index admission, when they get the diagnosis of heart failure, and they are at risk for death. Every time when you see the arrow down is a risk for death. After you treat the patient, diurese them, start them on GDMT, they can stabilize for a period of time, respond to treatment, to guideline therapies, and you assess them all for device therapy, including the ICD, defibrillator, or cardiac resynchronization therapy. Then this period is different from patient to patients. We have patients who have this period of stable for months. We have patients who are stable for years. Then once the patient starts going down, getting into one admission after the other, their clinical condition will start decline. One thing I want to point here is that every time the patient gets admitted, they are at risk for death, and they never come back to the same line. Also, the mortality risk increases with each subsequent heart failure hospitalization and with hypotension. That's why whenever we have patients get admitted more than 2 hospitalizations in a year or more than 1 time in 6 months, all these patients need to be seen by advanced heart failure, especially they need to be evaluated for advanced heart failure therapies. As you see, these patients, if they don't get any treatment, they're gonna end up dying. If they get, this is a curve, if they get on this arrow that is getting from 4 to 2, if the patient end up getting on advanced therapy, they go back to a better survival after advanced therapies. One of the tools we use to risk stratify patients is cardiopulmonary exercise test. And this is actually one of the testings that I do once I get when these patients sent to me to evaluate them for advanced heart failure therapies. I do cardiopulmonary exercise test because it is an objective way that tell me how the patient is doing. And it also can help me identify their candidacy for transplant listing or LVAD. So I have many times on this cardiopulmonary exercise. I order this test very often because sometimes I have a patient with really poor echo. I suspect that they will not be doing anything at home. Then they come and say, oh, I do everything. I don't have any shortness of breath. I don't have fatigue. So I send them to do the cardiopulmonary exercise test to objectively assess how they are doing. And it is not surprisingly when they come after, stop after 2 minutes of walking, and they have very poor results as I expected. So the cardiopulmonary exercise test is used for prognostication of ambulatory dilated cardiomyopathy patients who are considered for advanced therapies. we look at the peak VO2, we look at the VE/VCO2 slope, because they are recommended by the ISHLT, we have cut off to be considered for transplant listing. So basically, the patient will be exercising. They have the metabolic chart to calculate the oxygen consumption. We have these curves. We have calculate the peak VO2 and have the VE/VCO2 slope, and we can calculate the patient effort. So it's a very useful test whenever someone will have dyspnea. This can tell us if the dyspnea is related to the heart, related to the lung, related to deconditioning, related to body habitus. I personally order this test very often. As I said, this test help us prognosticate or risk stratify our patients. If the result of the test is good, means that the peak VO2 more than 20 ml per kg per minute, the patient has no exercise, oscillatory ventilation, his VE/VCO2 slope less than 30. It means that this patient has more than 95% survival within the next year, and the patient is low risk. There is no reason to start evaluation for advanced therapies now. On the other hand, if the peak VO2 is low, less than 12 or 14, depending on presence or absence of beta blocker, with a high VE/VCO2 slope more than 36, this means that the patient is at high risk for mortality. He has more than 20% risk for mortality, and this is the patient where should be referred, or if he's seen by a heart failure specialist, should be initiated all the evaluation and considered for transplant listing or mechanical circulatory support. So why do we need to identify advanced heart failure patients? I think everybody is now with me that it's important because of the mortality, high morbidity, and we want to identify these selected patients who will be eligible for this life-prolonging therapies, such as a heart transplant and LVAD or therapies. We want to identify them early before they lose their candidacy. The heart transplant is the most effective treatment, and the survival after heart transplant is more than 90% in the first year. Then we have the other option for patients, for selected patients, the durable LVAD can be considered as bridge to transplant, bridge to decision, or destination therapy. These are indications for heart transplant. It's a big list, but just to summarize, patients with cardiogenic shock, with low probability of recovery, we try to wean the inotrope. We cannot wean inotrope. We cannot wean short-term mechanical circulatory support. They are candidate for heart transplant evaluation, or heart transplant is indicated. It doesn't mean they are candidate, but the heart transplant is indicated. In this case, we have to start the evaluation to see if they are candidates. Again, all patients with limited exercise or tolerance, regardless of they are preserved ejection fraction or reduced ejection fraction, and if the patient has marked exercise intolerance on NYH class 3B or 4, despite maximal medical and surgical therapies, could be hypertrophic or restrictive cardiomyopathy patients. It could be complex congenital heart disease that is not amenable for surgical or procedural interventions. These people should be listed for transplant if they are candidates. Again, severe functional limitations, ischemic heart disease patients who have refractory angina, class 3 or 4, despite maximal medical, surgical, and interventional service. This is an indication that not many people know. We have patients who have normal EF, but these patients have like previous CABG, 15 to 20 stent, and they still have unstable angina, debilitating angina, despite all these procedures, and they get left heart cath, and the interventional cardiologist tells them there is nothing else I can do. At this stage, these people should be eligible to initiate a heart transplant evaluation, and they should be placed on the heart transplant list if they are a candidate. Another indication, if the patient has recurrent life-threatening ventricular arrhythmias, despite medical therapy, again, electrophysiology, everybody, we have them on the maximum antiarrhythmic drugs. We try VT ablation, either electrophysiology or surgical. And if the patient continue to have recurrent life-threatening ventricular arrhythmias, these patients should be evaluated for heart transplant. Lastly, all patients with localized cardiac tumors without metastasis could be also considered for transplant. Absolute contraindications means that if the patient goes anywhere, they will never be like, they come to Miami, they go to Chicago, they go anywhere in the world, they will not be candidates for transplant. So we have anyone who have limited life expectancy, less than 2 years, for whatever reason, they should not be considered for heart transplant, because we have too many patients with heart failure compared to the donors. We have scarcity of donor organs or donor hearts. So we would like to save these limited donors for people who are good candidates, who should live long enough to benefit from this organ. People with AIDS, with frequent opportunistic infections should not be a candidate. Patients with sarcoid or amyloid disease that has multi-system involvement should not be a candidate for heart transplant. If the patient have irreversible end organ damage, or like irreversible renal or hepatic dysfunction, they cannot be candidates for only heart transplant. Someone with irreversible renal dysfunction, they can be candidates for heart and kidney. Someone with irreversible liver dysfunction can be candidates for heart and liver, but not for a heart transplant only. If the patient has obstructive pulmonary disease with very poor FEV1, less than 1 liter per minute, they shouldn't be considered for heart only. Severe pulmonary hypertension with PA systolic more than 60, mean transpulmonary gradient more than 15, or pulmonary vascular resistance more than 6 Woods unit, they shouldn't be considered for heart only. And if they are young and candidates or for lung transplant, they should be considered for combined heart and lung transplant. This relative contraindications for heart transplant, I'm not going through the list. It's like basically age is relative contraindication. Some centers have cutoff of 65, some centers have cutoff 70, some centers have cutoff of 75. So this is a center specific. The rest of the list will depend on the center itself and how much risk they can adopt or acquire. One of the important things is the psychosocial instability. Some centers are more strict than others. For our center, we think if the patient have psychosocial limitation that can affect all their compliance post-transplant, compliance with medications, compliance with clinic visits, it's not right to give them a heart transplant. The rest of the list is there. So we'll talk about the LVAD. I should have included a picture for the LVAD. So LVAD is the left ventricular assist device. I have the old picture that I have in the rematch trial, but the indications will be similar to very much heart transplant with few exceptions. So stage D heart failure, EF less than 25%, with marked exercise limitation or marked or decreased functional capacity as measured by peak VO2 or 6-minute walk test. The only few exceptions ones that we cannot consider LVAD for patients who have restrictive cardiomyopathy or patients who have hypertrophic cardiomyopathy. It wouldn't be a good choice. We need dilated LV for the LVAD inflow cannula to fit in. We have contraindications which is same like heart transplant, limited life expectancy. If the patient has severe comorbidities like end-stage renal disease or severe liver disease, they should not go for LVAD. Patients with LVAD will require to be on anticoagulation post-VAD. Also, they will need to be on if they have active severe bleeding or chronic thrombocytopenia, LVAD is not an option for them because we're putting a hard wear like the LVAD is like a metal pump. So any active infection will be a contraindication. Important point, if the patient has severe independent RV failure, because when we put the LVAD will unload the LV and pump the blood to the aorta, and from the aorta to the rest of the bodies, and the blood will come back through the SVC, IVC to the right side of the heart, and it should be pumped by the right ventricle to the lung to circulate back to the LV. If the right side of the heart is so weak, LVAD is not going to be a good option. And it's kind of a challenging situation because we have to identify if the RV failure is related to LV failure. Sometimes it improves after LVAD, but if the RV failure have other reasons or additive reasons to the LV failure, usually it does not improve after LVAD. And we end up with situations that patients struggling with multiple complications post-surgery, patients requiring prolonged hospital stay, prolonged ICU if they get RV failure post-LVAD. The psychosocial barriers for LVAD is still there, but they are not as we are not as strict. I'm talking about our program, not as strict for psychosocial barriers for LVAD compared to transplant, because when you see a young person who's like in 20s or 30s who is dying and maybe has some issues with compliance, maybe the social situation is not the best, but you can talk to him, get the social worker or get the psych involved, and the patient want a chance to live at this stage. Sometimes we consider putting the LVAD to give them a second chance, and if they prove compliance post LVAD, transplant can be considered. As I mentioned, contraindication, anatomical HUCM or congenital heart disease or restrictive cardiomyopathy is not an option for LVAD. So the LVAD can be considered for bridge to transplant, destination therapy, bridge to candidacy and decision, or bridge to recovery. And I think this is the last slide I leave you with is mnemonic on the AHA ACC adopted is called I need help. This is just to give us idea when we need to start evaluation for LVAD or transplant, or when we need to refer patients to advanced heart failure therapist. Like I stand for inotropes, N stand for advanced NYHA classification or very elevated on NT-proBNP. E stand for organ damage, worsening renal and liver function. And when we say worsening, it means that we want to send the patient before they reach to the irreversible organ dysfunction. We want to send them when it's still reversible once we fix the heart failure or by either VAD or even transplant. E, ejection fraction less than 20. D, defibrillator or shocks, appropriate shocks due to VT. H, frequent hospitalizations. E, edema with escalating diuretics, someone you see in the clinic, and every time you see he's fluid overloaded, you go from Lasix 40 to Lasix 80. So Lasix 80 BIDs, and the Lasix is not working, you switch it to Biomix. Then the Biomix is not working, you are adding metolazone. This is a patient that is crossing the line from stage C to stage D, and he needs to be evaluated by a heart failure specialist. Low blood pressure, we talked about blood pressure less than 90, and it is most of the patients, our patients who are on guideline-directed therapy, or they will have a low blood pressure. But if the patient has persistently low blood pressure, less than 90, and cannot tolerate guideline therapies, that is the key. If the patient's blood pressure is low and he is on Entresto 97-103 twice a day, on Carvedilol 25 PID, and he's on Farxiga and spironolactone, he is on the 4 guideline-directed medical therapy, I would not consider this patient advanced. I would consider this patient advanced once I start titrating down all these medications and the patient become intolerant to guideline therapies, intolerant to ACE inhibitor, ARB or ARNI, intolerant to beta blocker because of hypotension. This is a patient I would know that he is crossing the line from stage C to stage D, and he needs to be evaluated for advanced heart failure. And lastly, B is the prognostic medications. Again, I already mentioned this, the guideline-directed medical therapy. This is the answer for the question, who should we refer to advanced heart failure? And I'm ready for questions.
So, Hoda, thank you very much for your great presentation, excellent talk. And it's really important to be able to see how the medical treatment achieves such great success over the years in managing this complicated scenario, this very severe EU patients. And as I told you before, now I am gonna make some comments about your presentation in Portuguese, and after that I'm gonna send to you some questions that we got here, okay? Então, boa tarde a todos, é um prazer muito grande participar dessa parceria entre a Universidade Federal de São Paulo e a Universidade de Miami, representada aqui pelo Miami Transplant Institute. Eu queria aproveitar para agradecer à professora Solange, ao professor Walter, por essa iniciativa e por nos permitir participar desse evento. Para todos que estão nos acompanhando hoje, eu gostaria de fazer alguns comentários a respeito da apresentação da doutora Hoda, e eu acho que os aspectos mais importantes são que nós devemos levar em consideração que hoje a síndrome de insuficiência cardíaca, pelo número de pacientes acometidos ao redor do mundo, não só aqui nos Estados Unidos, como vocês bem sabem aí no Brasil, nós estamos lidando praticamente com uma epidemia. O número de pacientes que têm o diagnóstico de insuficiência cardíaca ou que terão diagnóstico de insuficiência cardíaca só vem aumentando cada vez mais. E como a professora Hoda chamou a atenção, isso traz um impacto econômico muito grande para qualquer sistema de saúde. Tanto nos Estados Unidos, num país desenvolvido, como na nossa situação no Brasil, um país em desenvolvimento, os custos envolvidos são muito elevados. E isso se reflete no número de rehospitalização, de rehospitalizações desses pacientes, na morbidade que está envolvida no diagnóstico da insuficiência cardíaca. Para aqueles que são mais jovens, é claro que é muito importante levar em consideração que, uma vez feito o diagnóstico da síndrome de insuficiência cardíaca, a próxima pergunta obrigatória é qual a possível causa dessa insuficiência cardíaca. Então, é muito importante tentar se descobrir a etiologia. Eu acredito que o ponto principal da apresentação da professora Hoda foi quando ela chamou a atenção para mortalidade e para morbidade, mas principalmente para a mortalidade envolvida na insuficiência cardíaca. Então, isso é uma coisa muito importante, esses dados que ela apresentou precisam estar sempre presentes quando nós estivermos lidando com esse tipo de paciente. E, além disso, nós temos que levar em consideração o grande impacto na qualidade de vida de um portador de insuficiência cardíaca. Então, muitas vezes, é aquele indivíduo que vai tomar a polifarmácia, várias medicações, o uso de diuréticos e assim por diante. E tudo isso tem como objetivo, obviamente, retardar a evolução da doença e tentar melhorar a qualidade de vida. Então, é inegável o impacto que o tratamento clínico tem hoje no manejo da insuficiência cardíaca. E, para terminar os meus comentários, eu gostaria de dizer que, cada vez mais, é importante essa figura do especialista em insuficiência cardíaca, tanto o clínico quanto o cirurgião. Porque é um comportamento distinto. Muitas vezes a gente acaba tendo uma série de médicos generalistas tratando desses pacientes com o diagnóstico de insuficiência cardíaca. Sem dúvida é importante, mas existe um determinado momento onde o papel do médico especializado, do cardiologista especializado na insuficiência cardíaca se torna fundamental. E aqui nos Estados Unidos, isso é muito característico, onde os centros especializados no tratamento da insuficiência cardíaca contam com médicos como a doutora Hoda, que é um cardiologista basicamente dedicado ao tratamento da insuficiência cardíaca, e é muito importante essa interação com o cirurgião cardíaco. Então, acho que esses foram os pontos que eu gostaria de destacar para vocês e gostaria de pedir licença à nossa audiência novamente para fazer algumas perguntas para a professora Hoda, então nós vamos mudar mais uma vez aqui para o inglês. So, Hoda, we have some questions for you, and the first one is related with the cardiopulmonar exercise test. If you can elaborate a little bit more about the protocol, the way you deal with that, and the person that was making that question is Mary dos Santos Silva. Please, Hoda.
Okay, so the cardiopulmonary exercise test, basically, we put on metabolic card, we do baseline on PFT before the patient starts. We put the metabolic card on the patient, and then we exercise the patient using a treadmill or on bike, depending on the patient and depending on the symptom. And we measure the we measure the oxygen consumed and the carbon dioxide, And based on this, we will be able to measure like the maximum VO2, and we use it as diagnostic for prognostication or as a surrogate for the cardiac output. So it tells us, the way I describe it to the patient, when we do the exercise test, it tells me a few things. It tells me about your functional status, how much exercise the patient can do, and it also tells me how much the heart is able to keep up with the patient during exercise. There are multiple parameters that we look at during the exercise, other than the oxygen consumption. One of them is called RER, which is telling us if the patient will achieve the maximal effort. Because the patient can stop the test prematurely if he gets dyspnea or gets fatigue, but in fact, they didn't reach the level where their metabolism switch from aerobic to anaerobic. So the RER is the time when the patient switch from aerobic to anaerobic exercise is just telling us that this is patients reached their maximal effort and they did their maximum in the test. If the patient did their maximal effort, and we have these parameters that we look at to tell us if it's some respiratory parameters, some cardiovascular parameters that we look at to tell us if the patient is limitation is related to the heart or is related to the lung, or sometimes it's related to patient deconditioning. It's very complex topic. It actually needs a lecture by itself because the parameters that we look at is multiples.
Perfect. Professor Walter, do you have any other questions from the audience for Dr. Butrous?
I have been offline for a while, and I'm back. We have another.
Yes, Walter.
Yeah.
Yes, please go
We
ahead.
have another question now from Álvaro Perasso. How does you determine the appropriate moment to progress from VA ECMO to either LRV implantation or heart transplantation, the management of cardiogenic shock in advance of the heart failure? What's your strategy for this type of patients?
Okay, so the question is a patient with cardiogenic shock on VA ECMO.
Yeah.
How we decide about is this patient going to go for LVAD or going to go for a transplant?
Yes, that's the question.
Okay, it's basically depending on multiple things. We usually, if the patient, the easiest answer, if the patient has biventricular failure, LVAD is not an option. If the patient has more RVs and LV failure, LVAD is not an option. If the patient on VA and is not a candidate for transplant and his RV is adequate function, this could be considered as a candidate for LVAD as a bridge to decision or bridge to recovery, depending on the etiology of his cardiomyopathy. So I think the RV play a major role in our decision, plus the evaluation process, because when we start the evaluation for patients, we start from head to toe. We usually start post-mortem transplant and LVAD evaluation. And if the patient deselect himself from being a candidate to transplant, at this point we consider the patient as a candidate for LVAD DT if he has adequate RV function.
It's interesting, this question, Walter, because this last weekend, Hoda and me, we were covering the service together, and on Saturday morning, we came exactly to treat a patient in cardiogenic shock, and we ended up putting the patient on VA ECMO And for the next few days, Huda, we're going to have to decide about the next step on this patient. So it's a very common situation.
João, we have another interesting question from Álvaro Peraz as well. Hoda and João, what do you do when you have a patient in LVAD and the patient just dismiss the possibility or express a lack of desire for transplantation? What do you do in this type of patient?
Okay, so the question, as I understand, that patient has LVAD and does not want to have
go forward with transplantation. What's your... No, he dismissed the possibility of transplantation, and he doesn't want to go forward for a transplantation. What do you do this type of patient? You have a patient, advanced heart failure?
I saw one in my life who had LVAD.
And he's feeling well. He's feeling good with the LVAD. He's happy.
This is what I'm saying. It's a very rare type of population, because I've seen one in my life. This patient had LVAD for 7 years, and he was a bridge to transplant, and he actually was doing really well after LVAD. Without any complications, living his life, good quality of life, and he was 65 plus, and he decided not to compete for the heart for someone who may needs this heart more than him. So he was like thinking, I'm doing good with the LVAD, and maybe someone who's younger than me needs this LVAD, needs this heart. So I'm not competing with him. And this was the only one I've seen with this mentality. And I think it's a point of view. But I've seen patients, on the other hand, getting LVAD, have no complications, never in the hospital, waiting on the transplant list. When we have the new allocation system, patients with LVAD have been status 4, because the UNOS realize that patients with LVAD are stable, and they don't have to be high on the list. These patients is like keep asking the question, when I'm getting transplanted, and some of them actually limit their activities. They don't want to travel to Tampa, they don't want to travel here and there, all thinking that they might miss an opportunity to get a heart call. So yeah, I think if the patient doesn't want the heart, I think I will respect this. We are not forcing a heart.
Huda, you are stealing my thunder. I am gonna make the presentation about LVAD. Please stop talking now. I'm sorry, Walter. I'm gonna make a comment about this question, but I'm gonna do in Portuguese.
Okay.
Professor Walter e Álvaro, essa é uma questão muito, muito interessante. Como a Huda chamou a atenção, isso não é o comum, porque habitualmente os pacientes com LVAD, eles vão enfrentando muitas complicações depois do implante. Então, eu acredito que uma situação dessa deve ser relacionada àquele paciente que nunca teve uma infecção de driveline, nunca teve um sangramento relacionado à anticoagulação, nunca teve um episódio de baixo fluxo no LVAD, com o alarme disparando às 3, 4 da manhã. Então, eu imagino isso, eu não tive, não passei por essa situação, como a Huda falou, um paciente. Eu não vi isso aqui ainda. Então, eu acredito que só vai acontecer naquela situação onde o doente nunca teve nenhuma complicação do LVAD. O que cá entre nós é muito raro. É claro que com o HeartMate 3 agora, a bomba realmente funciona muito bem. Sem conflitos de interesse aqui, mas é muito raro o paciente não ter algum tipo de complicação no curso após o implante do LVAD.
Bom, a complementação do Dr. João Breda foi fantástico e complementou muito bem. Dr. Hoda, another question, please.
Yes.
That's from Dr. Moisés Andrade. Did you see any spike in myocarditis after the COVID-19 pandemic? And did you see any increase in the rate of heart transplantation in your institution or even in the United States?
So I can speak about my experience on here. Yes, we've seen myocarditis post-COVID, and the severity of myocarditis will be different from patient to the other. I can think of one patient that has severe myocarditis and cardiogenic shock. Doctor also took care of this patient with me. She was pregnant and she had COVID myocarditis presented with cardiogenic shock. And we got her through it with Embella, ECMO, and given high-dose steroid, and her EF remarkably improved, and she weaned off everything. This was like a success case. Initially, when we saw this patient, we initiated evaluation for transplant, because if she would not improve her EF, she didn't have any contraindication, she would have been recommended for transplant.
All right. Now, a question to Dr. João Breda. João, did you see any difference between these hearts after the COVID-19 related myocarditis and the ordinary hearts you see from conventional operation? Is there any difference between these two types of myocarditis? What was your impression related to the COVID-19 pandemics?
É difícil dizer, viu, Walter? Nós tivemos alguma experiência, alguns casos com miocardite depois de Covid. Esse caso que a Hoda mencionou foi uma paciente que tinha gravidez associada, então o impacto foi muito grande, mas ela recuperou completamente a função. Nós usamos um ECPELA nela, nós colocamos ela em ECMO com o Impela 5.5 para descomprimir o ventrículo, e nesse caso ela recuperou completamente a função. Eu acho difícil dizer. Atualmente, eu vi essa paciente recentemente aqui na clínica, e ela estava clinicamente sem nenhum sinal de insuficiência cardíaca e um ecocardiograma normal. Agora, a nível celular, a gente não tem essa resposta. A gente não tem essa resposta, saber qual é o impacto. Talvez no futuro a gente tenha a condição de saber. Mas agora eu não tenho a resposta.
Did you take any biopsy from this heart, from this pregnant patient?
No.
Any hint about the type of inflammatory reaction?
No. We did in a patient after a heart transplant. We had a patient. Did you remember that we had a patient after heart transplant who became COVID positive, and we did a biopsy there? But I don't. According to my recollection, there was no specific finding related. We didn't see any virus or anything in the pathology there. But it was the only case that I am thinking about now. I don't know if you have any other experience.
Dr. Hoda, would you like to comment?
I think the COVID-19 myocarditis and the heart transplant, all we have is like case reports, like each center reports its own experience. So from the few cases that we have seen here, none of them were transplanted. One I can remember one recovered EF or improved EF, and the other one actually deselected himself because of the complications, because it was one for multi-organ failure. So he is not a candidate for transplant.
Okay, we do not have any further questions. And then I would like to thank Dr. Hoda for your brilliant, outstanding lecture. It's a very interesting. People in Brazil liked it very much. And we'd like to thank you for your time you spent with us. Thank you very much. Thank you for João Breda as well.
Muito obrigado.
For invaluable contribution. Next lecture next week is going to be from Dr. João Breda. So we'll have a pleasure to have him with us. It will be a pleasure.
Valtinho, nós fizemos uma mudança na programação. Na semana que vem vai ser a aula da professora Bartira e a minha será na outra semana, ok?
Bom, acho que eu fui o último a saber aí. Tá bom. Não, mas tudo bem. Isso é normal na nossa atividade. Não, normal. Bom, thank you very much. Thank you all. We'll be back next week. I hope the audience have enjoyed this presentation. I enjoyed very much. This outstanding. Thank you very much. Bye-bye.
Thank you.
See you.
Pelo 8º ano seguido, a Unifesp foi reconhecida com nota 5, conceito máximo na avaliação do MEC. A Unifesp foi também destaque no ranking Guia da Faculdade, ficando entre as 10 instituições públicas com maior número de cursos 5 estrelas. Ela foi reconhecida pelo ranking da Times Higher Education 2023 como a 3ª melhor universidade do Brasil e como a melhor federal do país. São mais de 50 cursos de graduação e 70 de pós-graduação, voltados para as áreas de tecnologia, ciências exatas, humanas, biológicas e da saúde. Aqui é o seu lugar. Unifesp, universidade pública, gratuita e de qualidade.